from the RSNA. Welcome to Radiology Imaging Cancer Journal podcast hosted by the Trainee Editorial Board. I am Yashbir Singh from Mayo Clinic. We wanted to highlight the ongoing special collections we have. The neuroradiology head and neck collection will be concluding soon, and we will be launching the pancreatic hepatobiliary one next. Dr. Ashok is editor in chief for the neuroradiology one, and Lassie and Pallavi are leading the pancreatic hepatobiliary collection with the help from Dr. Wilkins on the interventional side. Dr. Wilkins is a professor of radiology and medical imaging in the Division of Vascular and Interventional Radiology at the University of Virginia. He completed his residency training at University Hospital Case Medical Center and fellowship training at the Medical University of South Carolina. He is a member of interventional radiology team that provides minimally invasive image guided procedure for arterial disease, venous disease, oncology therapy, traumatic vascular injury, as well as disorder involving the liver and kidneys. In addition to his clinical role, Dr. Wilkins is responsible for training residents and fellows in the area of vascular and interventional radiology, as well as participating in tumor board and multidisciplinary conferences. He is currently engaged in multiple research projects related to minimally invasive therapies with the focus on development of novel cancer therapeutics. Dr. Wilkins, what initially drew you to radiology during your medical training at Tulane, and when did you realize interventional radiology was your calling?
Yeah, sure. So when I was in medical school at Tulane, I guess every medical student is new to medicine when they first start medical school, but I was very, very green. I was the first person to go to medical school in my family. I came from a family of mostly teachers, some accountants, but mostly teachers. So definitely no one within the health profession. And so when I came to medical school, I really had no idea what doctors did, what a normal physician day was like, different types of medicine. I was really blind to it all. But I really found radiology during gross anatomy and found that I really enjoyed the puzzle of looking at cross-sectional slices and then trying to correlate that with what I was seeing during gross anatomy. That was kind of amplified when I started clerkships and was rotating through medicine and surgery and found that a lot of the decisions were made once we had medical imaging. And I found that to be the most kind of exciting part of the process of taking care of patients is that diagnosis part. So that's what originally drew me to radiology. So this was back in the day when I didn't have to make the decision about interventional radiology during medical school. I could make it later. And I found during radiology residency, which I did at Case Western Reserve University in Cleveland, I found during radiology residency that I very much enjoyed the clinical aspect of interventional radiology, seeing patients, helping them with getting ready for their procedure, and then taking care of them after and seeing them in clinic, et cetera. That I really, really enjoyed. It was merging both the medical imaging aspects that I liked so much with clinical care of patient, which I really enjoyed. And I found that the research that I was able to do in interventional radiology really kind of rounded everything out. So not only was I enjoying things clinically, but I enjoyed the research aspect of it as well.
So, how did your early experiences as a new interventional radiologist shape your approach to minimal invasive procedures, particularly in treating complex vascular and oncologic cases?
Yeah, so that's a great question. I think my early experiences, especially in training and then very early on as an attending, really helped me realize the significant impact you can have on a patient's care through both complex vascular and oncologic cases. And I think there's a lot of education that goes into the process. That is, most of my patients are very, very unfamiliar with what an interventional radiologist does. They're very unfamiliar with the types of procedures that we perform. And a lot of our time in clinic involves providing that education of what their disease is, what the imaging shows, and then how our procedures can impact them. So I think that's the thing that's changed probably the most about my care is how I approach patients and how I work with them in the clinic.
You wear multiple hats like clinician, educator, and researcher. How do you balance training the next generation of fellows while maintaining your clinical excellence at University of Virginia?
Yeah, you just described the tripartite mission, which is what most academic places are trying to do, and that's kind of our north star. Is that we want to take excellent care of patients, we want to provide education to the next generation of physicians, and we want to provide cutting edge research. So, how do I balance it? Not well. It's like I think it's a lot of work to do, but it's something that I really enjoy doing. I think one huge benefit of being in an educational environment in my practice, being in an academic setting, and having such talented residents and fellows. One of the benefits is that it forces me to constantly reevaluate my approach to procedures and patient management because I'm making sure that we're kind of at the forefront. And so being responsible for educating these residents and fellows forces me to make sure that we're providing the utmost level of care and really trying to teach to that next level of interventional radiologist that's coming out into the workforce.
Your work focuses on developing novel cancer therapeutics. Can you share what excites you most about the current landscape of minimally invasive oncologic therapies?
Yeah, I think this really gets to the heart of why I enjoy research in interventional radiology. And it's really that there is so much to discover, especially within interventional radiology. And one of the reasons it's so fascinating is that we have a lot of procedures that we do that are very effective and are standard of care for patients with different types of cancer. Yet, the research behind why they work and how best to optimize them is really limited. And that's just because we've had such good clinical evidence of their efficacy that we didn't kind of start in the lab and then work to translational research and then work into clinical trials to really optimize that. So instead, we've found something that was clinically effective. And now we're working backwards to evaluate that clinically effective procedure on the bench in translational research and figure out how to optimize it. And I find that really fascinating because, for example, chemoembolization, it's effective and it works, but how much drug gets deposited at the level of hepatocellular carcinoma cells? What is the optimal level of concentration within that space? And how do we determine that within an animal model? How much hypoxia is generated within that tumor microenvironment? How does that hypoxia impact those tumor cells, and where does that fit along the apoptotic pathway? All sorts of questions that we are only scratching the surface of. Yet it's a procedure that's done every day in most academic medical centers. And I find that really fascinating.
How has participating in tumor boards and multidisciplinary conferences influenced your approach to patient care and research directions?
Yeah, our participation in tumor boards and multidisciplinary conferences is kind of at the crux of how we in interventional radiology approach clinical care and approach research. We interact with darn near every service in the hospital, and we are very adept at making multidisciplinary treatment decisions. And so, when we're used to that in talking with vascular surgery about endovascular versus surgical bypass options, and working with pulmonology to discuss, conservative management versus large bore mechanical thrombectomy, or working with our hepatologist to discuss SBRT versus radiation segmentectomy. We're used to working with doctors from other disciplines to make those decisions. So it only makes sense to incorporate those folks when doing research on those topics. So I think those two go hand in hand when you're in academic interventional radiology.
What advice would you give to residents considering interventional radiology, especially regarding the evolving role of image guided therapies in modern medicine?
Yeah, so I think the person who really fits within interventional radiology are usually the trainees that are love radiology, love diagnostic imaging and the power of technology and changing management of patients and changing care of patients, but also enjoy that clinical side of medicine, and I want to have that incorporated into their everyday work. The icing on the cake are people that are naturally curious and love to work with their hands. All of that kind of is the recipe for an interventional radiologist. Being curious, I think, is one of the things I would recommend for academic interventional radiologists is to stay consistently curious and always wanting to learn more. The way I practice interventional radiology now is different than the way I practiced it in 2013. And I suspect in 2037, hopefully I'm still practicing interventional radiology, but I'll be practicing it differently then as well, which I find really exciting. So I would encourage people that enjoy change and kind of staying at the cutting edge of medicine to give interventional radiology a try.
And any personal message that you want to share for the trainee editorial board member of radiology imaging cancer.
I think I would echo what I previously said, is to stay curious. I think that the trainee editorial board experience for radiology imaging cancer is a wonderful opportunity for folks who are interested in academic medicine and wanting to learn more about the editorial process. As I mentioned earlier, when I came into this as a career, I was so blind to what was involved in academic medicine, from doing research to doing publication. So to have this experience as a trainee, I think really can be eye-opening for the trainee to see how much goes involved into writing manuscripts and reviewing them. And it gives you the ability to have a deep dive into the research that is being presented and what are the biases that are present within that. What are some good methodology? What is methodology that could use improvement, and how could that be improved? I think it gives you an inside look into what happens in these journals, and it's a wonderful opportunity. So my advice to the training editorial board members is take full advantage of it. Listen to as much of the back and forth during the weekly meetings as you can, and review as many manuscripts as you can, because it will pay dividends when you're writing your own, either now or in the future.
Thanks for spending time with us today. Special thanks to our guest, Dr. Wilkins, for his valuable insights. If you are enjoying the conversation, please rate, review, and subscribe wherever you are listening. Your interaction helps more listeners find the show. Check out Radiology Imaging Cancer. Link to the journal will be in the show notes. Today you heard from our team. Special thanks to our editor Kelly Myers. We will see you next time on the Radiology Imaging Cancer podcast.